All right, so we'll go ahead and get started here. And as people trickle in, then we'll just go ahead and add them. So I know you can't see me, but my name is Andrew Woods. I am the current president of the AOC PM&R student chapter. We are very, very excited tonight to host the first event of the 2021-22 Student Council, which is a talk called Bridging the Gap, Merging Exercise Science and Sports Medicine with Jeff Young. So Jeff was introduced to me through some of the executive council members on the AOC PM&R. He has extensive knowledge of what physiatry is, what physiatrists do, and tonight he's just going to kind of teach us from his point of view, his perspective, his world, kind of how we can operate with his world, with the sports medicine and exercise science world, and how we can kind of merge the two of them together. So I will stop sharing my screen and I will turn it over to Jeff. And Jeff, if I'll be here the whole time, so if you have any issues, just call out for me, okay?
All right, sounds good. First of all, let me say that, I just want to actually start off with a big shout out to the AOC PM&R for allowing me this opportunity, because it's just ridiculously exciting for me. And I also want to give a special shout out to Dr. Rob Gotlin, who I worked alongside for about 15 years, because if it wasn't for him, none of this stuff would have been happening or would be happening. And I also just really quick, I hope we get his name right, but Dr. Alex Levchenko and Andrew Yang, right, for the video series that I've been allowed to submit, and then obviously Andrew Woods and Brennan Smith for this opportunity. So very excited to get going with this. And Andrew, you definitely, set it up perfectly with what you said, because that's exactly what I want to do. And let me just start by saying that when I created this PowerPoint presentation, I was a little at odds, because I know that the theme needs to be and is going to be merging exercise science and sports medicine. But as hopefully most of you know, I'm going to be presenting in about a month at the mid-year conference, and one of my presentations is going to be for the students, and it's going to be some of this stuff, but a little bit more of like a 30,000-foot bird's eye view, like an overall of the continuum. And I thought to myself, as I was creating this, I'd be kind of remiss if I didn't at least include some of that 30,000-foot bird's eye view of the continuum, just so that you can understand the bigger picture, so that you can understand better how exercise science and sports medicine and the merging of the two fit into the big picture. So with that said, I'm not going to spend too much time on it, because I know the ultimate theme is going to be exercise science and sports medicine, but I just have 2 or 3 slides on the continuum that I want to discuss real quick, the roles that we play within the continuum, and then I'll get into the main theme. So with that said, so here we have a continuum, and it is a physician, or in this case, more specifically physiatry, rehab, fitness, and wellness continuum. And I don't know if you can read this or not, but I put here shortest or intermittent. So obviously from a patient standpoint, they'll see physiatrists definitely not as many times as they're going to see a physical therapist, and they shouldn't see him anywhere near as many times as the patient should see the exercise specialist. So this is going to be very intermittent, and 2, 3, 4, 5 patient visits over the course of X amount of time. And then in the middle of the continuum, you have rehab, and more specifically, I'm going to be talking about physical therapy, although it obviously can include chiropractics as well. But this is also should be intermittent in a perfect world, and actually it is intermittent, and it's a short stay unless the person has like ACL rehab or something like that, where they're going to be there for 6 to 9 months. But typically, as you all know, because of insurance dictating number of visits, and many times it's very short, 6, 8, 10, 12 visits, this is also a short stay. But on the other end of the continuum, the fitness and wellness, this is supposed to be lifelong. And this is actually where my passion is, because it is unfortunately seems to be a forgotten part of the continuum. So just speaking very generally, obviously from a physician standpoint, and especially with physiatry, you diagnose, you counsel and educate the patient on the diagnosis, and you discuss treatment options and the overall plan. From a physical therapy standpoint, they're going to treat, they're also going to counsel and educate, and ultimately they're going to create a discharge plan. And then from the fitness and wellness end of the continuum, we coach and train. We also counsel and educate. We motivate and guide, and we try to get our clients to reach and hopefully on a properly designed program exceed their goals. And the main point of this slide, and one of my main just passions in my professional life right now, is the fact that physical therapy too often is the end point. You're referring patients to physical therapy, and it's not continuing on to exercise specialists. It shouldn't be the end point. Instead, it should be just a short stop, and it should be the transition point to the fitness and wellness domain. Home exercise programs should not be the norm. And unfortunately, and I know there's always outlier situations, but unfortunately for the general population, home exercise programs are the norm. And the problem is that they're just too low volume, low intensity, low in variety, and patients just don't stick with them for any length of time. A lot of it, the reason is because of that, because of the fact that they're a Band-Aid more than anything. And while not everyone who gets referred off into the fitness and wellness domain is sick, some are healthy and they just need musculoskeletal rehab. Since this country is so sick, and so many people do suffer from either overweight or obesity and all the conditions that can be associated with it or otherwise, what we need to do is take sick individuals and move them into the fitness and wellness domain. And this is where physiatrists can really play a huge role. The reason why I put doctor's orders there is because from a physical therapist standpoint, they're going to listen to you because they need your referrals. And what I wish was a more common thing is that from a physiatrist standpoint, and putting myself in the place of a physiatrist, I would definitely be telling the physical therapist that I want such and such patient to not be placed on a home exercise program upon discharge. I want this patient to be referred off to an exercise specialist because we also need to be working on their overall health and not just the joint pain or condition, musculoskeletal condition that they're here to see us for. So I just wish that it was more common for physiatrists to see themselves as the quarterback of this overall continuum and realize that the power and the role that you have and can play in making sure that the patient is guided through this entire continuum and not just stopping at physical therapy, which ends with a home exercise program and then keeps the patient in this purgatory, this physical therapy purgatory, where they're not getting any stronger, they're not improving tissue strength and health, and then they're right back to getting injured again, and they just keep going through this circle. And then the other part of the continuum is the patient themselves. And I'll fly through this slide real quick, but basically on one end of the continuum, you have it's a motivation and means continuum. So on the one end, you have the patients who have lower motivation or maybe they just don't have the means for whatever reason. It could be finances, could be the area they live, rural or socioeconomic issues or whatever, where they just don't have the means to be able to, for instance, join a traditional health club. And then the other end of the continuum, you have people with higher motivation or they have the means to be able to join a traditional health club, etc. And then obviously in the middle. But the main thing I want to say about this slide is that from a physician or a physiatrist standpoint, it's just so important that you're discussing their exercise program with them. And obviously we might not be able to do this with every single visit, although that'd be perfect world, but you want to discuss the exercise program, just using me personally and all the, when I'm not going to say physiatry, but when I go see my family physician or whatever, they never talk to me about my exercise program. And even though I hopefully look like I exercise, they still should. And it's just not happening. So from a stages of behavior change standpoint, it's the part of the physician's job to learn during the course of the visits which stage they're at. And just looking at this chart real quick, I don't know if you can see it or not, but if they're at the pre-contemplation stage, this is where you want to start creating awareness and hopefully changing values and beliefs. And once again, the whole doctor's orders thing, I just wish the doctors understood. I'm not pointing fingers directly at you because I don't know you. So I'm just speaking generally, that I wish doctors understood the power they have, because patients are going to listen to a doctor way more than they're going to listen to their family or coworkers or friends, generally speaking. Anyways, then as you move up the continuum or the stages, at the contemplation, here's where you can begin to persuade and motivate. At the preparation stage, you begin, now they intend to take action, and you can start to educate them. And then when they're at the action stage, you can facilitate it. So it goes right back to the previous continuum, where you can facilitate this by making sure that the patient doesn't just stop with physical therapy and home exercise programs, but they continue on into the fitness and wellness domain. And I've spoken with a ton of sports medicine practitioners, whether it's physiatrists, physical therapists, and so on, who totally agree that pain is a motivator and an objective point of reference that you can use in your discussions with them to move them along this continuum, and basically explain to them, among other things, that to reduce pain and the risk of re-injury and to improve their overall health, it's so important to increase tissue strength and overall conditioning. And once again, a lot of times, just by the nature of physical therapy and the restrictions that insurance puts on it, this just isn't happening to the point that it should in physical therapy. So this is where strength and conditioning and exercise specialists come in. Oops, sorry for that. Forgot my little arrow. But anyway, so now we're moving on. I just want to quick, once again, bird's eye overview of the stages of rehab, just to kind of put my presentation into a little bit more perspective. Generally speaking, and again, I'm just being very general, so there's going to be outlier situations depending on the situation, but generally speaking, stage one in physical therapy is to reduce or negate pain and inflammation. Let me also say that you don't necessarily need to completely leave stage one before you can go to stage 2 or 3. All these stages, or especially stage 1 and 2 or stage 1 through 3, can overlap. But generally speaking, stage 1 is to reduce or negate pain and inflammation. Stage 2 is to, the primary focus is to restore joint range of motion to at or near normal. And again, you can do these simultaneously or concurrently. Stage 3 is to restore, or the focus is on restoring and improving motor control and eccentric control, and to begin to balance strength around the joint. And I don't know if you can see the chart here, but the emphasis is commonly includes single joint exercises and emphasis on the lowering or eccentric portion of the movement, and isometric holds when applicable. And then stage 4, and this is really too often the missing component and the missing link in physical therapy, which in a perfect world, you'd move them on to stage 4 and keep them here for as long as you can before discharging them, and then discharging them into stage 4, where they continue to restore or improve motor control, but it involves more of the kinetic change, or in other words, compound movements like sit to stand or squats, hip hinge such as deadlifts or hip thrusts or bridges, various pressing movements like shoulder press or chest press and rows, things like that. You want to begin to include force absorption exercises, and you really want to start increasing variety of exercise, set volume, which we'll talk about a little bit later in the presentation, a wider spectrum of repetition ranges as opposed to 2 or 3 sets of 10 or 2, 3 sets of 12 would, and then you also want to start including the total body rather than just focus on the area of the body that is injured. So focusing in just a little bit more closely on stage 4, athletes obviously move from rehab to strength and conditioning, and so should everybody else. So this again is just really hits on where my passion comes, because obviously athletes need it, but the general public needs it every bit as much as athletes to move on to strength and conditioning. And especially the older you get, the more important it becomes to be on a strength and conditioning program. And unfortunately, the way the system is set up, we are not doing justice to the general population and older populations. So too often the general population is discharged, as I've mentioned previously, with low volume, low intensity, low variety home exercise programs, and only for the part of the body that was injured or in pain. Underdosing and underloading are huge problems, not just in rehab, but also in the fitness world, especially with older populations. For those who come in sick, they tend to leave physical therapy remaining sick because of the short stay and the fact that they're only focusing on the injured area, when instead their overall health should be addressed along with the musculoskeletal conditions. So back in about 2015, I presented at Mount Sinai. I'm in New York City, and I presented at Mount Sinai's first annual physiatry conference. And after the conference was over with, I had a physiatrist come up to me, and it was the first time I was ever asked the question, how do I know the difference between when I should refer to a physical therapist versus somebody like you? And I think I did a pretty good job of answering the question that back then, but now I've been asked the question many times and I know exactly how to answer it. So here's the answer to the question. If the patient needs the following modalities, which I'll just let you read, or I should say, or if the patient is experiencing pain, if the pain the patient is experiencing is sudden or rapid as opposed to gradual, it occurs at the beginning or middle of the range of motion, it includes swelling or inflammation, it's sharp, stabbing, or burning, it includes numbness or tingling, and or it significantly affects their activities of daily living, then you pretty much need to refer to a physical therapist. I consider that to be on a continuum or of discomfort or pain. I kind of call it being in the severe domain of the continuum. But otherwise, the patient can be directly referred to an exercise specialist. So while I'm referring to myself here and my peers, don't diagnose or treat injuries, what we can do is avoid the area completely when necessary. We can adjust foot position, hand position, joint or joint angle, whereby doing so alleviates pain. We can reduce the range of motion into their available pain-free range of motion, or the load, whereby doing so alleviates pain. And we can revolve exercises for an injured area around joint-friendly exercises, which I'm not going to have the time to really get into that, what joint-friendly means today, but in the next presentation, I'll definitely get into that a lot more, what I mean by that. But we can revolve exercises for the injured area around joint-friendly exercises in a graded progressive fashion, and basically place the person on a total body program that includes therapeutic exercise for the areas that need therapeutic exercise. And although I just put this slide in because this is something that I think is important to include at some point down the road in my presentations, so that you can understand better what is the difference between a kinesiologist, exercise physiologist, and clinical exercise physiologist, what makes a trainer qualified. Obviously, I'm going to have my own biases when I answer that question. What differentiates the different certifications ACSM, NSCA, American Council on Exercise, National Academy of Sports Medicine, etc. How, from your perspective, would you find a qualified trainer? Is there a database? And if so, how do I access it? And what does the vetting process look like? And I'll also just quickly say that I hope you'll keep my contact information, because when it comes to those last two bullet points and finding a qualified trainer and helping with the vetting process, those are definitely things I can help with. One of the things that's going on right now with me, that's barring something completely unforeseen, is going to happen within the next 2 months, is the National Strength and Conditioning Association, which, for those who aren't familiar, is one of the governing bodies. There's two governing bodies in exercise science: the American College of Sports Medicine and the National Strength and Conditioning Association. We're getting ready to launch a what's called a performance-based special population special interest group, and I'm going to be chairing it. And just through that alone, and through my involvement with the American College of Lifestyle Medicine and some other medical organizations and fitness organizations, I definitely have access to, no matter where you live in the country, I can help you find a qualified trainer when it gets to that point. So now we're going to get into sports medicine. What I just call it sports medicine. It's like my version of sports medicine 101. And then I'll show how to merge it with exercise science 101. So to start, there are many factors associated with and increase the risk for injury. And these are just examples that I'm going to list. It's mainly just to get a point across. So this is definitely not a comprehensive list. But one would be improper form, especially under moderate to heavy loads and or under a condition of fatigue. So for example, if I were to stand up right now and do a body weight assisted stand and buckle my knees and have a rounded back, chances, it's not a heavy load and I'm not under fatigue. So I'd have a very low risk of injury, but put me under moderate to heavy load and or under condition of fatigue, and obviously the risk increases. Insufficient warm-up is a factor associated with and increases the risk for injury, especially prior to an explosive movement or a maximum effort event, such as a 1-rep max deadlift. Movement restrictions or areas of tightness are associated with and increase the risk for injury. And lack of stability under a load, especially when the tissue is on stretch. So these are all factors that are examples of factors that are associated with and increase the risk of injury. But there's only one cause of injury. And the cause of injury is that in the moment of time that the injury occurred, the injured tissue or tissues lack the capacity and therefore were not able to tolerate the load, stress, or force that was placed upon it. And this underscores the need to increase tissue tolerance, both from a strengthening standpoint and from a conditioning standpoint. Or in other words, place the person eventually on a strength and conditioning program, whether they're 8 years old, 98 years old, or anywhere in between. So now moving on, and it's associated with what I just said, there are 6, or as you'll see, potentially 7 components of a healthy musculoskeletal system. So what I'm going to do is I'm going to list them. I'll give them a little bit more clarity, and then I'll have a slide where I kind of tie it all together to make it just a ridiculously simple concept to understand. The first is neuromuscular or motor control, which very simply defined just means that in any movement or resistance of movement, and what I mean by that is like a plank, or even like 2 linemen in football, hitting each other and resisting the forces of each other. The right muscles are producing the right force at the right time. And we can break that down further and say that the prime movers are doing the primary work, the assisters are assisting, and the stabilizers are stabilizing. But ultimately, neuromuscular control, if those things are happening, then it is manifesting itself in the form of proper form. So if the person is exhibiting proper form, then obviously the right muscles are producing the right force at the right time. So therefore, neuromuscular or motor control and proper form are synonyms and are a component of a healthy musculoskeletal system. Moving on to number 2, strength is a component of healthy musculoskeletal system. And since there is a force component to neuromuscular control, and the stronger your muscles are, the more force they can produce, strength plays a major role also in neuromuscular control. You want to, for example, show the person what they're doing incorrectly if they're exhibiting, if they're not exhibiting neuromuscular control, or if they have improper form, show them what they're doing wrong, um, and obviously how to do it right. Repeat the pattern over and over, and then increase their strength in that movement. And it's not the only way, but it is a primary way to improve neuromuscular control. And obviously, the weaker you are, the more at risk you are for injury or joint pain. Also known as local muscle endurance, is a component of a healthy musculoskeletal system. And the reason why I call it strength endurance is because strength is also a component of local muscle endurance. And the reason why I have this chart here is because um, the American College of Sports Medicine defines general fitness from a strengthening or a strength training program standpoint as the 6 to 15 repetition range. So it's kind of the middle of this continuum. And if you look down at the intensities, you're basically training the person in the heavy, moderate, and light repetition ranges. But if you look down at the adaptation, in the 12 to 20 repetition range is the optimal. It's not the only, you could go higher than 20 for strength endurance, but the optimal range is the 12 to 20 repetition range. So that's how you're going to improve that from a practical standpoint. And then obviously heavier loads and lower repetitions is going to be the optimal way to increase strength. But once again, one of the main points is that strength plays a major role in neuromuscular control. It obviously plays a major role in strength, and it plays a major role in strength endurance. Next up is joint stability. And I just put these bullet points because I just want to make the point that joint stability has way more to do than just scapular stabilization exercises, or shoulder protraction for the serratus anterior, or standing on one leg with your eyes closed. Those all play a role, but your large global muscles, such as your glutes and your pecs and your quads and your hamstrings, etc., they're all stabilizers too. So we want to strengthen it's just another reason to strengthen the total body. We want to strengthen both large and global muscles and your smaller and intrinsic muscle groups, with both static, such as standing on one leg, and dynamic exercises. And in a perfect world situation, we want to include multi-directional exercises, such as an example would be multi-directional lunges, are a great way to improve joint stability. And they're also a great way to improve spatial awareness. But even things like karaoke or grapevine, side to side shuffling, or if you're familiar with karaoke, walks or jogs, or backwards walking and things like that, help improve spatial awareness and are a component in joint stability as well. And then the fifth, and I also, before I get to this one, the fifth one, let me also say that while you can improve joint stability without strengthening, strength also plays a major role in joint stability. You pretty much are going to need ultimately to, especially with eccentric or the lower eccentric strengthening, or the lowering component of a movement, and isometric strengthening. But the point is that strength also plays a major role in improving joint stability. And then you have posture and alignment. From an upper body standpoint, that's going to include things like forward head posture and rounded shoulders. From a lower body standpoint, things like knock knees or dynamic valgus, or pronation at the foot, which can lead to those things. But strength also can, especially with the upper body, strengthening can play an important, maybe not necessarily a major role, but an important role in posture. Dynamic valgus is you're going to be wanting to strengthen your gluteus medius. Upper body, you're going to want to strengthen your posterior chain, upper back, mid back, etc. And then moving on to the sixth one, we have mobility. And mobility has 3 subcomponents, which are flexibility, myofascial mobility, which you're going to improve through trigger point release. And then your joint capsules, such as your ankle, hip, and shoulder capsules, can either be tight normal, or hypermobile. And the reason why I put this up is because a lot of people think that flexibility and mobility are synonyms. And although they're extremely closely related, they have slightly different definitions. Flexibility is the available range of motion around your joint, whereas mobility is the amount of usable range of motion in dynamic loaded conditions. So here's another situation where strength comes in. Mobility is where strength and flexibility intersect. So they're closely related, but they have slightly different definitions. And then the reason why 7 may or may not apply is because it's going to typically apply more to athletes. Rest and recuperation, that is typically going to apply more to athletes than the general population. And I mainly say that because the general population, at least in my experience, typically will train 2 or at the strength train, that is true, 2 or at the most 3 times per week. And so therefore they have 4 or 5 rest days just by the nature of their program. And so rest and recuperation typically, obviously you have your outlier situations, but it typically is not going to be much of an issue for a lot of the general population. But those are the 6 or 7 components of a healthy musculoskeletal system. And that's kind of my version of sports medicine 101, or at least the application portion of it. And what it all leads to is that no matter what the condition is, or no matter where it is, where they're tight, we want to get them mobile, because this is the way you balance flexibility and mobility around joints. Where they're weak or hypermobile, we want to get them strong, because this is the way you balance strength. We obviously want to ensure proper form, which is going to maintain or improve neuromuscular or motor control. In a perfect world situation, we want to get them out of a beginner range of strength, which is where progression comes into play. And this is the corrective, no matter what the condition is or no matter where it is. So when I'm designing programs, I'm always thinking about those components of a healthy musculoskeletal system. I always kind of see programs through the eyes of those components. But really what it comes down to is, if I'm just ensuring that they have proper form on each exercise, and I'm hopefully including in a perfect world situation, like multi-directional exercises, then there's going to be the improvement of their neuromuscular control. And then obviously I'm going to, well, as you're going to see, as I get to the exercise science part, I'm going to train them across the spectrum of repetition ranges, get them stronger within those repetition ranges. So I'm improving their strength, and I'm balancing strength around joints. I'm improving their flexibility by placing them on a proper flexibility program and removing movement restrictions. And when you do those things, from a post-rehab general fitness and medical fitness standpoint, that is the corrective. So now we get to exercise science 101. There are 2 primary categories when you're designing a strength and conditioning strength training program. When it comes to aerobic and flexibility programs, that's just not within the scope of this presentation. We absolutely can cover that, and I would love to cover it in future presentations, but for now, I'm just talking about strength training programs. There are 2 categories to program design: the initial program design, which is known as the familiarization phase, and then ongoing progression. So once they get out of the familiarization phase, how are we going to progress them? And that's where periodization comes in. So focusing on the initial program design first, the American College of Sports Medicine has a phrase, start low, progress slow, which really just means start conservatively and progress in small, tolerable increments. So generally speaking, and once again, no matter everything I'm saying, there's always going to be outlier situations, but I'm not talking about the outliers. I'm talking about the masses who are not the outliers. So generally speaking, you want to start someone somewhere around 10 repetitions per set. Could be 8, could be 10, could be 12, but somewhere around 10 repetitions per set. And during this phase, you want your focus is determining the individual's available pain-free range of motion. You're teaching them the names of exercises, proper form, the flow of a session. You're using what's called rate of perceived exertion or rate of perceived effort scales to determine your initial loads, which is something I'm actually excited to tell you a lot about because it's ridiculously important, but it's not um, part of the scope of this presentation. I will absolutely include it in the next one. But you want to use RPE scales to determine their initial loads, to determine their progression. You begin to slightly increase their effort as this phase progresses, which really means that you're starting to increase their proximity to muscle failure. So you aren't taking them anywhere near muscle failure. You're, for instance, on a scale of 1 to 10, where 10 means muscle failure, you might only start them at like a 4 or 5, where technically it's like a warm up. The load is like a warm up load or a warm up set. And you might only progress them to about a 6 or a 7 during this phase. But the point is that you want to progress and get them a little bit closer to muscle failure as you progress through this phase. And then you're obviously using verbal, visual, and tactile cues to try to help establish mind-muscle connection. So that's the focus of this phase. And the end of this phase or the stage is determined by the client is now showing proficiency in movement. The proper form is starting to become natural for them, and you don't have to do nearly as much cueing. And the intensity has reached approximately a 7 on a 1 to 10 scale, which once again, in the next presentation, you'll understand very clearly exactly what I mean by that. But the point is that you're starting to move from warm-up loads to a true working set, kind of the bottom end of a true working set. And when you get to that stage, they are, and so for some people that might mean 2 or 3 weeks, and for other people it might mean 2 or 3 months, but that's what determines the end of the stage. And at that point, it's time to progress them. And then there's a zillion ways you can progress them, but I'm going to show you the way I do it with just about everybody. And that is by placing them on what's called a linear periodized program. So once again, we started at 10 repetitions per set during the familiarization phase. And what I'll do is I'll move them, most, but not all clients, but most of my clients will be moved to 12 to 15. So we're actually going to lighten the load a little bit because they're doing more repetitions. They're in that strength endurance part of the continuum. And we're going to stay there for about a 3 to 4 week phase. And my primary goal, it's not the only goal, but the primary goal is to increase strength within this phase so that by week 4, for example, let's say they stay there for a month. By week 4, they're a little stronger in every exercise than they were in week 1. And what that does is it prepares both their mind and their body for when we dropped just 2 repetitions. So it's not a big drop. 2 repetitions, we increase the load accordingly because they're not performing as many repetitions in a set. We stay there for a 3 to 4 week phase. And once again, the primary goal is to increase strength within the phase. And that prepares their mind and their body for when we drop to 8 to 10 repetitions per set. We stay there for a 3 to 4 week phase, do the same thing. And then at that point, it becomes kind of an executive decision between the coach and the client. Maybe we'll drop them to 6 to 8. Maybe we'll swing them back up around to 12 to 15 and go through it again. But for most people, including older adults, at some point, it might not be the first time through, might not even be the second time through these phases, but at some point, you should be able to progress them to the 6 to 8 repetition range. And once again, more detail on that in the next presentation. Actually, let me go back real quick. So in other considerations for this phase is now we are starting to increase we're not taking, I never take clients to muscle failure. There just really isn't a need. But you do want to go to what's called near muscle failure, which on a 1 to 10 scale is going to mean like a 7, an 8, or a 9 if 10 is muscle failure. So you want to be somewhere in that 7 to 9 range. And for most people, they should be able to tolerate it, especially if you're choosing joint-friendly exercises. You really want to start to vary this intensities so that, because you don't want every session to be light, light, light. You don't want every session to be hard, hard, hard. You want to ebb and flow. And that's part of what periodization means. It means ebbing and flowing. So we're ebbing and flowing and varying in session intensities. We're starting to include more variety in your exercise selection. And we're also starting to increase set volume. More on that in a later slide. In any case, and then by increasing strength in each of these repetition ranges, just by its very nature, we're going to improve strength endurance, and we're going to increase overall strength. We're going to improve or increase lean muscle tissue and joint stability. So we're going to do all those things just by the very nature of putting them on a periodized program. Another thing I want to point out is I mentioned previously that the American College of Sports Medicine defines general fitness from a strengthening standpoint as the 6 to 15 repetition range. And this is a very simple and systematic way to go through that range. You're starting at 12 to 15. So you're starting at the high end with lighter weights, and you're systematically moving them down into the 6 to 8 repetition range in a perfect world. So it's a perfect way to adhere to ACSM guidelines. So just very quickly going through, there's a lot of variables involved in the design of a strength and conditioning program: frequency, intensity, volume, rest, choice of exercise, exercise tempo, proper form, and there's more than just that. But just very quickly, I'm going to go over, give a little bit more clarity to frequency, volume, intensity, and rest. So for the general population, time and desire typically is what determines their frequency. Most people, especially if they're paying a trainer, are only going to train 2 or at the most 3 days per week. But the governing body guidelines is to strengthen every major muscle group in the body 2 or 3 times a week. Because if you're only doing it once, you're giving it 6 days of rest, and it's going to be nearly impossible to get out of a beginner range of strength if you're only strengthening once per week. So you really want to try to strengthen at least 2 to 3. 4 or more if the person has the time, desire, or can progress to that. And basically the difference is that if they're strengthening 2 to 3 days per week, you want to put them on a total body program. And if they're strengthening 4 or more days per week, that's when split routines come into play. And it might be like, for instance, 2 lower body workouts and 2 upper body, or 2 push workouts and 2 pull workouts. From a volume standpoint, the main thing I want you to know in this presentation is that it typically refers to your set volume, or in other words, how many sets you're performing within the scope of a session and within the scope of a week. Typically in the very beginning, during the familiarization phase, you're going to actually, I put here, begin with 2 to 3, but you might actually begin with just 1 to 2 in the first week or 2 of the familiarization phase. In most situations, you're going to be able to quickly progress them to 2 to 3 per session. But if you think about it from a math standpoint, if they're only training 2 days per week, and they're only, for instance, doing 3 sets per major muscle group, that's only a set volume of 6 sets per week. And what we really want to try to at least realize exists and have a focus, not early on. This is something that you wouldn't do early on, but you want to at least have it in mind to try to progress the person to. And that's a minimum of 10 sets per week for your 3 large muscle groups: your legs, back, and chest. And actually probably even by its very nature, it's going to include shoulders, because you're kind of hitting shoulders when you're doing back and chest exercises. But this is actually an evidence-based guideline. There's a review that came out about 2 years ago that talked about set volume. And from a optimal standpoint, basically the conclusion of the review, and I'll pass it along to you if you're interested in it, was that 10 sets per major muscle group per week was kind of that minimum threshold to really start to get optimize the person's adaptations to a strength and conditioning program. So it's something just to be aware of and to try to progress in a perfect world situation, the individual too. So for example, if they're doing 3 set total body sessions per week and 3 sets per session for legs, back, and chest, that's a set volume of 9 per week, which is just shy of the 10. So at least you're in that range. But anyways, it's just to give you some info to be aware of. And then intensity, there's 2 types of intensity: objective and subjective. Once again, subjective refers to those rate of perceived exertion scales, which I'm going to hit on. It's one of the most important things that you can be aware of in strength training, because you can be on the worst program ever. And if you're putting a lot of effort into each set, a subjective effort, then the program's going to work for a while. It might not be the greatest program, but it's going to work because of how much effort you're putting into. Or you can put them on a ACSM periodized program, but if the effort that you're putting into the set is not high, then it's kind of defeating the purpose. So I'll be talking about that a lot in the next presentation. But for today, what it means by objective intensity is you are taking your feelings, your emotions, and your rate of perceived exertion out of the equation, and you're only looking at the loads that you're lifting. So if the load is such that you can only perform 1 to 4 repetitions, then objectively that is known as very heavy weight. If the load is such that you can perform 4 to 8 repetitions, then objectively that is known as heavy weight. In the 8 to 12 repetition range, that's moderate weight. 12 to 15 is lightweight. And if you can perform a set of 15 to 20 repetitions, even though subjectively it might feel tough at the end of the set, the weight you are lifting objectively is very lightweight. So the point is that the continuum moves from very heavy to very light and everything in between, and is dependent upon the repetition range that you work out in. Rest and recuperation is something that we can just talk in more detail in another presentation. Basically, there is some science behind rest between sets and between sessions, but it's just outside of the scope of this presentation. I'm getting towards the end of this presentation now. I'm wrapping it up here. When we get to the case studies part, and actually you'll see in my last slide that I actually think that in my next presentation, I can spend about half of it or so kind of on this kind of stuff to wrap it up, the merging of exercise science and sports medicine. And I think I'll have the time to go over a brief case study. And then obviously after that, we're going to be, the primary focus is on case studies. But one of the themes you're going to see as we move through these series of lectures is that the patient, and I'm sure many of you or most, or maybe even all of you already know this, the patient is not their X-ray, their MRI, or their ultrasound. And especially as they move through physical therapy and go on to post-rehab, general fitness, and medical fitness, the diagnosis actually rarely significantly, it might slightly affect the treatment plan or the program design, but it rarely significantly affects it. More on that in a second. So, and the other theme you're going to see as we go through these case studies, which is the reason why I really wanted to start off with this 30,000 foot bird's eye view that I did today, is you're going to see over and over that my points are, no matter what the case study is, no matter what the condition, and no matter what the joint, your overall framework is the ACSM and NSCA guidelines that I described in previous slides, with the familiarization phase and the periodization, where you also insert joint-friendly exercises within that overall framework. And that's going to really pretty much define your overall resistance training program design. And then you also want to include the mantra that I mentioned in a previous slide, where they're tight, get them mobile, where they're weak or hypermobile, get them strong, ensure proper form, and try to get them out of a beginner range of strength if possible. So that's really going to be the themes you're going to see over and over with my case studies. So yeah, with certain conditions, with certain joints, you're going to need to know the details about, what for instance, a meniscus tear and the different types of meniscus tears and how that might affect program design. But ultimately what it comes down to is you still want to put the person on ACSM and NSCA protocol, include your joint friendly exercises, the overall mantra, as opposed to, and this is one of my pet peeves in the fitness world, it just makes it so much harder to understand when you say, oh, for this condition, we got to do that. And for that condition, we got to do something else. And this even applies to disease. For diabetes, this is the type of the program that you put somebody on. And for multiple sclerosis, you got to put them on this program. And for hypertension, you got to put them on this program. It's just not true. There's way more similarities to program design than there are differences, which I look forward to getting into. And so with that said, the differences in program design from person to person are going to be the special considerations for each condition, and this applies to disease and to musculoskeletal conditions. The frequency that the person is going to train is going to vary from person to person, and therefore their weekly set volume, because weekly set volume is very much dependent on their overall frequency, or I shouldn't say dependent, it's associated with, highly associated with their overall frequency. The rate of progression will differ from person to person, and their overall motivation, which tend to be correlated as well. But ultimately, we always want to think about progressing them and making sure that we don't underdose and underload, which is just too much of a common issue in rehab and even in the fitness world. And then their available pain-free range of motion is going to differ from person to person, and therefore the associated exercise selection. Maybe someone with knee osteoarthritis, grade 3 or grade 4, we can't have them do loaded squats, but maybe we can put them on a leg press or do hip hinge exercises with them, et cetera, et cetera. So, and it's also going to be based on what the individual has access to. So exercise selection for someone who's on a home program is going to differ a lot from someone who has access to traditional gym equipment. So the conclusion is that there is a physician, rehab, and fitness / wellness continuum, and the fitness and wellness domain needs to be a much larger and emphasized part of the continuum, and that physicians need to understand that they play a primary role, doctor's orders, in quarterbacking this continuum and ensuring that the fitness and wellness domain isn't forgotten. And then the sports medicine 101 revolves around those components of a healthy musculoskeletal system. Exercise science 101 revolves around the ACSM and NSCA guidelines, et cetera. And then the next presentation, what I'd like to do is a quick review of this presentation and then cover what I call the RPE method, which is how to determine safe initial loading and rates of progression. Give more detail about what I mean by joint friendly exercises for like knee, hip, low back, shoulder. And then if you want to, I can include the frequency, intensity, time, type, and progression principle for flexibility training and aerobic training, or we could include that, sometime down the road. And then I should have time also to do the first case study. So with all that said, I know hopefully we have at least 5 minutes, or I don't mind going a few minutes over if you want to, for questions or comments.
Yep. So thank you, Jeff, very much. I have enabled it so that everybody can unmute themselves. You can also put your questions in the chat. So if people, I know I had a couple of people that messaged me asking if they could ask a question. So feel free to type it into the chat or to jump on the mic.
Hello, can you hear me? Okay.
I can.
So yeah, so I have 3 questions. First of all, thank you for the presentation. Super helpful.
Thank you.
The 3 questions are related, so I'm just going to throw them out there and then you can answer them in whatever you feel best.
Sure.
So first, going back to the beginning of the presentation, you talked about how there's sort of a stop at physical therapy and we need to continue that to health therapy. When I was working in kind of an underserved area, a lot of the reasons why we did stop at physical therapy and continued with home exercises was because our patients just didn't have the ability to pay for continuous monitoring. Is something like exercise specialty covered by insurance and other things? To follow up on that, you mentioned that physiatrists and other doctors would be sort of quarterbacking this, but you also mentioned that they have the shortest interaction. So are you advocating that we have more contact with patients, see them more frequently to follow up on this, or are you advocating that we still stay in that short interaction role? And then my final question is how, like, a lot of the reasons why home exercises are preferred is because patients just don't have the time to go in to see these things. So how are you addressing the concern of like patients saying I can't take time off work regularly to go see an exercise therapist?
Right. Okay. These are awesome questions. Just real quick, remind me of your first question, just a quick blurb.
Yeah, the first question was coverage by insurances and other things. If they have to pay out of pocket, that can be a barrier to seeing that.
Yeah, so fitness is an out-of-pocket expense. One thing that a lot of people, whether it's physicians, PTs, and exercise specialists and the public aren't aware of, is that most of your major insurance companies will offer reimbursements. So, and typically the way it really just depends on the insurance company and the individual's policy. So they actually have to be the patient actually has to be the one that calls their insurance company to find out. But a lot of, your Aetna and Blue Cross Blue Shield, et cetera, they offer reimbursement programs. And typically the way it works would be the patient has to show that they are that they've done X amount of sessions, like, I don't know, maybe 30 sessions or 40 sessions over a 6-month period, and then they'll get reimbursed. It's not a whole lot. It kind of depends. It could be like here in New York City, it wouldn't be a lot. It's $200 to $300 typically for the reimbursement. So here in New York City, with how high it is to have a trainer, that's not a whole lot, but in other areas, it might be a significant um, way to afford the session. So anyways, it's just something to be aware of. And then also there's something called the FIT Act, PHIT, that I know that it has gone through the Senate. I think it's the Senate or maybe it's the House, and it's at the Senate right now. But if and when it gets approved, then insurance will have to start reimbursing for like group sessions and one-on-one. I'd have to, just know that there's something called the FIT Act, PHIT. You can Google it and look up more what it means. But it actually looks like for the first time after lobbying for decades that this is actually going to go through. So that's one thing. Also, yes, I absolutely do advocate for physiatrists to, once again, there's a perfect world situation, but I just want doctors in general, and here I'm speaking to physiatrists, to understand that the power they have and the role that they can play, and the whole doctor's orders phrase, and the influence that they can have in the patient going through this continuum, but also with the physical therapist too, and just trying to get them to understand that home exercise programs should not be the end all. And let me just say along with that through my involvement with the American College of Lifestyle Medicine since 2015, I've been really fortunate to meet a bunch of physical therapists who either held or currently hold leadership positions in the APTA. And actually, as of last week, I've just been brought on, and it became official last week. I'm going to start uploading, submitting Bridge the Gap content on everything we're talking about right now. And they're going to upload it to the APTA's, it's called a hub page, and also their learning center. So I'm starting to get involved with the APTA on this topic as well. And also related to this and related to your questions, one of your questions about, and I just am currently forgetting exactly what your question was, but it was related to like home exercise programs and an inability to maybe afford a trainer, or their inability to afford a trainer, or maybe their just desire to be on a home exercise program. I've been involved with the Medical Fitness Association since 2015 as well. And the current chair of their board of directors, his name is Jeff also. When I was involved with the ACLM as the chair of a fitness and medicine group, I created what I called a patient referral subcommittee. And I teamed up with Jeff from the Medical Fitness Association, and we literally created an entire course on what are the perceived barriers, which is basically what your question is related to, such as I don't have enough time, like from a patient standpoint, I don't have enough time to exercise. I don't have enough finances. I don't have the motivation. Insurance doesn't cover it. You name it. And we created an entire course to address and answer these perceived barrier questions. So this is also something in these series I would love, to maybe, like, for example, a 3-to-1 ratio. We'll do 3 presentations or lectures on case study, and then break it up with one on diving deeper into exercise science, or diving deeper into this type of stuff. But the point is that these barriers are perceived, and there's always ways around them. And from our standpoint, from the exercise specialist standpoint, we totally understand that we're not going to be able to capture 100% of your patient population, or 80% or 60%, maybe not even 40%, but we'd love to capture 10%, 20%, and so on, and move as many as we possibly can into the fitness and wellness domain, even if it's just for the initial guidance and the first 5 sessions or something like that, just to get them started properly. So hopefully I answered most of your questions the best I could.
You did. Thank you.
All right. Anybody else have any questions? All right. Well, thank you all for attending tonight. Like I said, this is the first of hopefully many presentations, especially with Jeff. For those of you that aren't already following us on Twitter and Instagram, you can get us at AOCPMNR, and you can find Jeff at JY Kaniz. We also have another event coming up this Friday for a Women in PM&R discussion panel. It'll start at 8 p.m., so I really love to see everybody there as well. In the meantime, if you're an AOC PM&R student member, this presentation will be posted hopefully by next week. Just let's go through some editing and review, so you'll be able to access it again in the student portal. But thank you all so much for coming. Jeff, thank you so much for this presentation. I think it was fantastic.
Thank you. Thanks a million.
Yeah, we look forward to having you back. So if anybody has any questions, feel free to reach out to us. But otherwise, everybody have a great night.